everyone, welcome back to another session in dentistry and more. Let's continue our question paper discussion of public health dentistry. We are into part 6 of the series, so we have one more part that will be the last session of public health dentistry questions. We thought of 6 parts, but we have some few more questions to be covered, so we added one more session. So in this part 6, we have 3 chapters, that is healthcare delivery systems, dental auxiliary and finance in dental care. Among these 3, dental auxiliary is very important. Mostly essay question will be asked from dental auxiliary. And finance in dental care, it's very confusing, very tough chapter. So many short notes and short essay could be asked. And healthcare delivery systems, it's not very frequently asked chapter for university paper, but you can expect a few questions from that also. So we'll start with healthcare delivery system. That is how the health is being provided to our people. We have two sector, public sector and private sector. Public sector, we have this is a 3-tier system: primary, secondary and tertiary. Primary is the first level of contact through primary health centers and sub-centers using village health workers, ASHA workers. Whereas the secondary level, in primary level, basic procedures will be done. I mean vaccination, immunization, sanitization, health promotion, health education, and one or two doctors will be there at primary health centers. Sub-centers, there will be just one doctor, and supporting staffs also very less. There won't be any inpatient facility in primary health centers mostly, but sometimes it will be there. Whereas the community health centers or district hospital, that is secondary level, where most of the treatment can be done, surgeries, deliveries, because all specialist doctors will be there, lab technicians will be there, lab facility will be there, x-ray facility will be there. It is almost like a hospital. And the tertiary level, that is specialist hospital, medical colleges, where all the treatment will be done. This is how the 3-tier system is arranged. Then we have health insurance schemes. In our country, the insurance schemes are not very prevalent, but still a very minor percentage of people can avail it, mainly the central government employees and the IT sector people. Under central government employee, they have employees state insurance, that is ESI plan, then CGHS, that is central government health scheme, then universal health insurance scheme, and even defense services, railway, hospitals are also providing healthcare. In private sector, that is the majority are depending on private sector through private hospitals, polyclinics, general practitioners and clinics. And we have also a traditional indigenous system, that is Ayurveda, Unani, Siddha, homeopathy. Then we have many voluntary health agencies, NGOs in our country, Red Cross Society, Kushta Nivaran Sabha, so many other, I don't remember many names. National health programs such as tuberculosis control program, tobacco control program, AIDS control program, many are there. It's still going on. One of the question, short note could be NRHM, that is National Rural Health Mission. It is to provide accessible, affordable, accountable care to the poor and vulnerable people. It is started in 2005, and for a 7-year period, mission shall cover entire country with focus attention on 18 states which has weak demographic. So it is mainly using ASHA workers, that is accredited social health activities. Actually, this ASHA worker is an upgraded version of village health guide. So they act as a link between the people and primary health center. So they basically address the issue of sanitation, hygiene, nutrition, safe drinking water, and basic determinants of good health. They just communicate with people because the ASHA worker is from the same community, and they can definitely make a significant change in people's health. So under the NRHM plan, there are many key components, that is to create ASHA workers, that is 2.5 ASHA workers for a cadre of 2.5 lakh villages in 4 years, creation of village health scheme, then strengthening of sub-centers and supply of drugs, and supplementing vitamin A and folic acid deficiency for the children, and promotion of private sector for achieving public health goals. So that was NRHM. Now we have NUHM, that is National Urban Health Mission, that is focusing on urban slum areas. The second question could be ASHA, that is Accredited Social Health Activist. So every village will be having a female ASHA. They will be chosen by and accountable to the panchayat, and they act as an interface between community and the health system. So this ASHA would act as a bridge between ANM and village, and they are accountable to the panchayat. And she'll be an honorary volunteer receiving performance-based compensation. They promote immunization, referral, escort service, and construction of the toilets and healthcare delivery programs. So they will be having a drug kit, and they will be of minimum 8 years standard of education, and they have equipped with this drug kit, and they will be trained for doing the basic health services. That was regarding the ASHA. Now we have primary dental care. So sometimes question will be coming as a primary dental care that is not present, literally not present in our country, because in India primary health centers is not having dentist. Only 2% of PHC has a dentist at service. So the reason for lack of primary dental care is there is no oral health policies existing in our country, and there is no separate oral health budget allocation. Okay, it is a health budget, there is no oral health budget, and lack of commitment and awareness of general public, politicians, and planning commission towards oral health, and non-existence of health insurance schemes regarding the oral health, and lack of research. So all these attributes to the lack of dental care at a primary care at primary level, and lack of orientation and non-availability of baseline data of prevalence and impact of oral disease also could be a problem. Now we are into the most important chapter of this session, that is dental manpower or dental auxiliary. So the question will be define and classify. That is the first part. Then any auxiliary could be asked as the remaining part. It could be a hygienist or a therapist or a school dental nurse or surgery assistant. So you need to know the functions of every auxiliary, let it be a non-operating or a operating. So before that you need to buy out the definition. So auxiliary is a person who is given responsibility by a dentist so that this person can help the dentist in rendering the dental care, but who is himself or herself not qualified with a dental degree. And we have two classification, non-operating and operating. Non-operating is auxiliaries which are not working on a patient, that is surgery assistant, secretary or receptionist, lab technician or health educator. Whereas operating auxiliary, they have the permission to work on a patient but under supervision of a dentist. They can be a school dental nurse, dental therapist, dental hygienist, and expanded function dental auxiliary. So we'll start with non-operating dental auxiliary. The first one is dental surgery assistant. So it was started by Dr. Edmund Sickles in 1885. He's from New Orleans, USA. So he hired a woman for the first time by a dentist, and he called the woman as lady in attendance, just to help the patient in draping the patient, to giving the patient a napkin. So it is mainly to attract female patient. So it acts as a four-handed dentistry, and it reduces the stress and workload of a dentist. So this doctor has started appointing a dental auxiliary for the first time, that is dental surgery assistant, that is Dr. Edmund C. Kells. So the duties are preparation of patient, preparation for giving like mouthwashes, napkins, sterilization of instruments, restoring the materials, presentation of documents, and aftercare of person. So you must be knowing all the duties of a surgery assistant. Whereas a receptionist, do you know how the receptionists act and what is a job? I don't need to tell you. The secretarial work and patient reception duties. And dental technician. Dental technician, his main function is fabrication of appliances as per the directions and prescription given by the dentist. And denturist is permitted to fabricate denture directly for patients without dentist prescription. So denturist is a term applied to those dental lab technicians who are permitted to fabricate dentures directly for patients without a dentist prescription. They may be licensed or registered. So the process of denture making is known as denturism, and the people who are doing this known as denturist. Okay, the ADA, American Dental Association, defines denturism as the fitting and dispensing of dentures illegally to the public. Okay, there is a lot of controversy regarding this, because they are not supposed to create any dentures without dentist prescription. So Denmark uses the term denturist to describe a special category of dental technician who sits at an examination to enable him to prescribe, make and fit removable dentures without supervision. So denturists in the state of Maine, denturists are permitted to take impression and fit dentures, but only under the direction of a dentist. And in Tasmania, a state of Australia, was the first place where technicians were legally permitted to provide a prosthetic service. Okay, so in Tasmania, it is legally permitted. In Denmark, they used denturist term, but they can also do the dentures without supervision. And in the state of Maine, denturist can take impression and fit dentures, but only under direction. But ADA is vigorously opposing this dentures, because of this quality assurance is not there. Okay, that is regarding the denturist. Now we have dental health educator. In a few countries, dental surgery assistant also being given a duty to teach the patient or educate the patient. Now we have operating dental auxiliary, that is the first one, New Zealand school dental nurse. So it was started in Wellington, New Zealand by T.A. Hunter in 1921 at the Dominion Training School for Dental Nurse. The training period was 2 years. So it is known as the father of school dental nurse, T.A. Hunter. Okay, the similar auxiliaries present in Britain, they are known as New Cross auxiliaries. They started in 1962 because one of the training school was located in New Cross in South London. That is why that name, New Cross auxiliaries. And dental nurses were present in Malaysia, Singapore, Thailand, Vietnam, Indonesia and Hong Kong, and even Australia. In Australia, they are known as therapists. Even they are present in Africa and America. In Canada also, in Saskatchewan, dental nurses are present, where someone other than dentist is legally allowed to drill the tooth. They can drill the tooth. Saskatchewan dental nurse in Canada. So their duties are treating school children. Basically, one person is allotted 500 children. They have to monitor the children, or they have to do the treatment at a 6 months interval. They can do prophylaxis, placing filling in both permanent and dentition, extracting teeth under local anesthesia. So like that. The second operating auxiliary is dental therapist. They are permitted to work but on a written treatment plan by the dentist. They cannot do independently. They can perform all functions as a school dental nurse but are not allowed to perform endodontic procedures and interpretation of x-rays. So they are known as dental dressers in UK. Okay. And they came into being due to the shortage of dental nurses. So in 1962, we already see New Cross auxiliaries present in UK. They changed the name to therapist. Okay, before it was known as New Cross auxiliaries. Now they are known as therapist. In 1979, its name changed to. So the therapists are present already in Australia, but in Britain it was known as New Cross auxiliaries. But in 1979, they were named as therapist. So they are permitted to work based on a written treatment plan by the dentist. Oral prophylaxis, extracting under local anesthesia, topical application, interpretation of X-ray and endodontic procedures were not allowed. So dental hygiene is the only one operating auxiliary present in our country, or the approved by Dental Council of India. So Dr. Alfred Civilian Fons is known as father of dental hygienist, who appointed Mrs. Irene Newman as his hygienist, the first dental hygienist. So the first training school for dental hygienists started in November 1913. That was a course of 7 months. So these are their duties: scaling, polishing, radiograph, bleaching, occlusal splint, sealants, photography, and the preventive agents application. Now we have expanded function dental auxiliary, that is a dental assistant, that is a non-operating dental hygienist, that is an operating auxiliary. They receive further training. Okay, they already have some duties, but they receive expanded duties. So the technotherapist, they are the last scale service application of the expanded duty made in Philadelphia. So in Philadelphia, the expanded function people are known as technotherapist. In Canada, they have the assistant or hygienist. They get 4 levels of training, that is certified dental assistant, preventive dental assistant. It can be a dental hygienist and dental hygienist with expanded duties. So their duties, they are either assistant or hygienist, but now after expanded function they do topical application of fluorides, desensitizing agent, pit and fissure, carving, removing matrix band, removing rubber dam, nitrous oxide usage, removing sutures, removing and replacing ligature wire. Now we have frontier auxiliaries. So what is frontier auxiliaries? In rural areas where dental workforce is very minimal, because most of the workforce is present in the urban area, so nurses and former dental assistant can be useful at this area when they are provided with a minimal training. So they can be deployed to the rural areas. So they can do prophylaxis, relief of pain, referral, fluoride rinse, denture repair, health education, all can be done using nurses and former dental assistant. But we should give them training. And we have some new auxiliary types. WHO recommended new 2 types of auxiliary in 1959, that is dental licentiate and dental aid. Okay, so dental licentiate is a semi-independent operator trained for 2 years. So they can do oral prophylaxis, cavity preparation, extraction under relay, draining of dental abscess, and treatment of supporting tissues of the teeth. Whereas dental aid, they perform duties which include the first aid procedures for such as relief of pain, extraction under relay, control of hemorrhage. The former training is 4 to 6 months. Okay. That is dental licentiate for 2 years training, whereas dental aid is 4 to 6 months training. And the last part of this dental auxiliary is the degree of supervision. So degree of supervision, there are 4 types based on the American Dental Association, that is general, indirect, direct, and personal. How the dentist is supervising the auxiliary. So in general supervision, what happens is dentist is not present in the dental office. He authorizes the procedures and dentist does as per the authorization and as per the directions it was given. Whereas indirect supervision, authorization of dentist is same, but the dentist is present in the dental office. Whereas direct supervision, dentist personally diagnose, personally authorize, personally evaluate before leaving the patient. So there is a direct supervision. Whereas personal supervision, actually the dentist is working. In these three cases, that is general, indirect, direct, the auxiliary is working on the patient. He's being supervised, but personal supervision, the dentist is working. Okay. So general, dentist is not there. Here dentist is there, but he is busy with some other work. But here the dentist is not busy, or he is very actively monitoring the case. That is direct supervision. So that was about auxiliary. Now we are into the last chapter of this section, that is finance in dental care. So the finance in dental care in Sobanpitra is the most toughest chapter. It is very difficult because the problem is in India or Indian scenario, finance is dental care. It's very simple. We have just one method, that is pay for service. There is no insurance present in dental sector. Just pay for service, that is the patient goes to clinic, treatment is done, and he take the money or take the card or do the UPA transfer. Done. The procedure is done. There is no third party, there is no insurance, nothing is there. But in this chapter, what is given is the complete scenario of United States of America. So what we are studying in this chapter is the scenario of America. So that is why it is becoming a very difficult chapter for the students. So spending more time on finance, it's not worthy. Unlike the epidemiology, I previously said the more time you spend on epidemiology would definitely benefit you, because it is like a knowledge gaining. When you go for your masters, definitely it would help. But finance and dental care, better you don't spend much time on this, but try to understand the concept and study this only for your exam, because this is nowhere benefiting you, because it is not the Indian scenario we are talking about or we are going to study about. So anyway, I will start with finance in dental care. So this is the most common asked question, that is a payment. Okay, so we have 5 methods. Private fee for service, that is the Indian scenario. Post payment plan, we don't have post payment plan. Private third party prepayment plan, we don't have any of this plan. That includes commercial insurance companies, non-profit organization. It can be a Delta plan, Blue Cross, Blue Shield, and it can be a prepaid group like HMO, and it can be a capitation plan. This all comes under private third party prepayment plan. Okay, prepayment, just like prepayment, we are paying before the start of procedure or before availing the procedure. But post payment plan, first we receive the treatment, we avail the treatment first, then we pay. Okay. Then we have salary. Salary is also present in our country, and public health programs are very less in regard to the oral health. So private fee for service in our country, it is very administratively easy, to a traditional form, but the low income people cannot afford this. And post payment plan, which is also known as budget plan, it is just like taking loan to pay. Okay, so we first borrows money from, or patient borrows money from bank or some other agency and pay the dentist fee. Okay, so once application is approved and the treatment is done already, but we have made our paperwork done before that, and we have uh, got everything ready, so the bank pays to the dentist. Okay, once the treatment done, bank pays to the dentist, and we have a period of time where we can repay to the bank on an installed amount. So it is mainly indicated for low income people, and it started in Pennsylvania in 1930s, but it is actually utilized by middle income people, and it was nowhere reaching its purpose. So the treatment will be done at first. and later we pay the money. So dentist is anyway paid. Once the treatment is done, he is paid by the bank. But before starting the treatment or before going to the dentist, we need to make our paper ready. So you might not be getting the point, because this is not what we see in our country. So this is all American scenario. So anyway, this is how it is. Post payment plan, you know how the SIM card is like post payment plan and prepayment plan. Post payment means you use it for 1 month and at the end you pay for it. Prepayment, you pay at the beginning of your month and then you use it. Okay, it's just like that. And the private third party prepayment plan, there will be a third party. In post payment plan also there is a third party. Your third party is the bank. So first party is the patient, second party is the dentist, and any person other than these two is a third party. So first you understand the concept, that is a third party. Okay, it can be an insurance agent, it can be a bank, it can be an agency, it can be an association, so it can be a firm, anything it can be, who manages these two parties. Okay, so prepayment plan is just like that. We pay before that service. The dentist and this first and second party, there will be administered between these two. And salary is just like at the end of the month we get a fixed salary. There will not be any incentives. It won't be a very encouraging method of payment for the dentist. And public health programs, this is all programs of USA and UK. So public health programs by Medicare is programs of USA, and national health insurances of UK. One more question that is short on health maintenance organization. This is a prepaid group. Prepaid group means it works as a group of people or a group of dentists with many specialties or one specialty. It is just like a dental hospital. Hospital will be having all the type of treatment, all specialities, everything will be done there. Okay, so many doctors will be there. Similarly, health maintenance organization is in that fashion. You need to think of a dental hospital. So there are four components. Okay, the components are four principles. So there is a very difficult definition for this. It provides services to the individuals they are enrolled in the organization. So any person in USA or a European country has to enroll or has to take a insurance, because there is no direct first party second party arrangement in those countries. You have to go through a third party and you have to fix an appointment and make your papers ready before getting a treatment. That is why it is becoming very difficult, very costly treatment over there. So this is four principles, that is there will be a system of healthcare and the treatment provided through this healthcare, and a group of people they are enrolled in this HMO, and there will be a reimbursement mechanism. This is how it is being worked. Okay, there is a dental hospital network and the treatment services provided through this network, and the number of people who is taken membership in this HMO, and how the dentist who is working under this organization being paid by the third party. So HMO act as a third party here. They act as a administrator between the dentist and the patients. So it can work as a staff model, group model, and IPN, primary care capitated. That is a group model. Staff model, HMO pays individually to the each person in the dental hospital. It's all hypothetical scenario. Whereas a group model, HMO pays a bulk amount to the dental hospital, and the authority of dental hospital divides the money and give to the employees. Independent practice association, if you don't want to work in a hospital setup under HMO, you can work as an independent practice association still under HMO. Okay, and the last one is primary care capitated network. That is a mechanism of capitation fee where the dentists are paid based on the number of people they are checking rather than the treatment they are doing. Now the question is insurable risk. So when a risk can be insured, under these 5 criteria a risk can be insured. That is, it should be precisely definable. So a damage is happening to our vehicle should be definable damage, then only the company will give us insurance, and it should be of sufficient magnitude and it constitute a major loss, and it should be very infrequent. If something happens very frequently, they won't give insurance because the insurance company will be in a losing uh, side if they are giving claims for every damage, or if the damage is happening very frequently. So their expectation is they take a policy from 100 people and only 10 cars will be damaged, and it should be of unwanted nature. Okay, this accidents and this damage is always an unwanted nature. They are not expecting it, they don't want that, and it should be beyond the control of individual. That is why the risk is or these 5 reasons are the thing where risk can be insured, because this is not coming anywhere near to our health, because health is under control of individual. Health is definitely a wanted nature, and we get diseases very frequently and we cannot define it properly, and the loss, defining a loss is very difficult in regard to health. So that is why health insurance is very crucial and very tricky one. So what insurance company did to overcome this problem, they have made some changes in policies regarding health insurance. That is, they don't give entire money to the patients. They keep a sharing business, that is having patients pay share of cost, and they don't give insurance for every treatment. They limited range of services. Cosmetic restorations are not covered, implants are not covered, and they offer coverage only to groups. Okay, they don't give for every people, because a 40 plus patient would be having definitely many dental problems, so they don't give much insurance to the aged people, and they always keep waiting periods because they want to give insurance for a normal person who is having a unexpected problem. So in order to maintain that policy, they keep waiting period and make sure that they don't have any pre-existing disease, and they keep pre-authorization and annual expenditure limit, and they before that policy only they inform the patients that these are the annual expenditure limit and these are the procedures would be treated, or the diseases would be treated. Now the capitation fee is another mechanism where an established sum on a monthly or yearly basis will be given to the dentist as a reimbursement mechanism based on the eligible patient. So this money will be paid regardless whether the patient utilizes the care or not. Okay, so the dentist will be getting the money. So in HMO there is, we have seen this capitation fee was there. In return, the patient can receive a prescribed set of services over a specified period of time. So this is basically on eligible number of eligible patients, and regardless of the treatment. If patient uses the treatment or not using the treatment, the dentist would get the reimbursement for that person. Now we have another question, that is 90th percentile. It comes under Delta Dental Plan. So this is a little bit of maths. You need to imagine 100 people are writing an exam where the highest mark is 100. Okay, and you got marks of all 100 people, and you're putting the marks into a ascending order, and the highest mark, it could be a 95 or 94 or 83, 84 depending upon the toughness of the paper. The highest mark will be the 100th percentile, because under that mark or under that value all 100 people's mark will be present. So that highest mark is 100 percentile. Similarly, since you are putting it in ascending order, the 90th person or the 90th highest mark will be the 90th percentile. So under that value there will be 90 people or 89 people if excluding that person. Similarly, 50th percentile is a value under which 50% of the observation lies. 40 percentile means it is the value under which 40% of the observation lies. So in order to get that exact percentage, you need to put the marks or the remuneration or reimbursement in a ascending order, and you have to calculate the value. So if the exam is tough, the percentile will be coming down, and if it is very easy, it is going up. So here you can see the 90th percentile is $14. That is 90% of the dentists are paying or asking charges $14 or less. Then 80 percentile, 60 percentile is $13. 50 percentile is $12.5. That is 50% of the participants are asking the rate of 12.50. So 50th percentile is 12.5, 90th percentile is $14. Hope you understood this. You need to think of two scenarios: 100 people writing an exam of 100 marks, and the highest person is 100 percentile and the lowest person is a 0 percentile or a first percentile. And 90th percentile is a person who is scoring a 90th position. That value is 90th percentile. Now we have post payment plan and finance, that is we already seen budget payment plan. Indian scenario, that is fee for service is very common, dental insurance is very negligible. We have some ESI plan, CGHS, defense and state government hospitals. Now we need to learn about the type of payment. Okay, how the patient can pay the third party under three mechanisms: deductible, which is also known as front-end payment, co-insurance and group insurance. So this is how the patient pays to the third party. Okay, so we are talking about a three-party arrangement. Okay, first party is a patient or dentist, second party is a dentist or patient. You can make it vice versa, no issues, but the third party is a third person. So deductible or front-end payment is like a fixed amount that patient pays to the third party. Like if insurance of deductible 1000 means 10,000 means if damage occurred, the owner pays only 10,000, but he may reach up to 1 lakh of reimbursement. Whereas co-insurance, where the patient also pays a part of it. So here it will be 40-60%, then he has to pay 40,000, and the remaining 60 only will be reimbursed by the insurance company. Group insurance is insurance which is applied or which is offered to group, okay, just like school children. Whereas the reimbursement, how the third party is giving the money back to dentist. It can be a UCR mechanism, table of allowances and fee schedule. UCR mechanism is the most apt method, the best method of finance. UCR is usual, customary and reasonable fee. UCR, where the usual is a usual charge for a given service by an individual dentist. It depends on his qualification and the area where he is working. So usual fee of dentist can be widely varied. A BDS doctor charges 500 rupees for a scaling, whereas a MDS doctor charges 1000 rupees. A rural side scaling will be charged 300, but in a urban setup it will be 500. So similarly it will be different for each patient. Customary fee when the fee is customary, when it is in range of usual fee charged by the dentist of similar training and experience for same service in specific area. It is nothing but in a city where the dentist, just like I said, BDS people charge 300, I mean 500 for scaling, and MDS people charge 1000 for scaling. So it is a customer friendly fee. Okay, so usually in use here mechanism, the ultimate fee is not decided by the dentist, it is decided by the third party. So how they deciding is they take the usual fee and customary fee of all dentists who are practicing there, and then they decide. So even if a person or a dentist keep his usual fee is very high, there is no point, because the third party or the Delta Dental plan, they planning to use a percentile mechanism where the individual dentist fee is nowhere coming for the calculation. So when a person's dentist fee, so customary fee is in an area where the charges are in a range of usual fee, that becomes customary. So both are meeting means it is reasonable. So suppose a person, usually in an area, in a town, the scaling charge is 500 for BDS people. A person, a BDS doctor named A is charging 700, and a person named B charging 300, and a person named C charging 500. So usually it is 500. So only the charge by the dentist C can be said as customary fee, because others are not in the range of the usual fee decided by the third party. Okay, it's very confusing. Whereas table of allowances is defined as a list of covered services for each services. So the dentist will be having a list of allowances what they get, okay, for each treatment from the third party. So the problem is, if sometimes the dentist fee becomes more than what they supposed to get, so what they do is the remaining amount, because when he starts filling, usually the filling allowance is 100 rupees, but he might have to add more amount of filling material, so the charge will be 150, but he would get only 100 rupees from the third party. So what he do is the remaining 50 he takes from the patient. So this method is not satisfactory because the patients are often unaware that the plan may not cover them in full of dental care, because the patient might think that they will not be charged anything, but some dentist might ask extra amount. That is a problem of table of allowances, because the fixed allowances only will be given to these dentists by the third party. So similarly, there is one more term, that is fee schedules. So there will be the third party is using the main payment of many dentists in a certain area to decide the fee schedule. Now we have the main question, that is a Delta Dental Plan. This is a non-profit organization which is synonymous with Dental Service Corporation. They usually subjected to insurance law of the state, that is the state where they are planning to operate in USA. Its first name was National Association of Dental Service Plan, NADSP, in 1966. Later they changed to Delta Dental Plan in 1969. It has got two types of dentists practicing under: participating and non-participating. Participating dentist has to pre-file their usual and customary fee. Before I was explaining in detail, I don't know how much concept you would get. So this is how it is. First we need to file our usual fee. My usual fee for a scaling would be 700 rupees, but the customary fee in that area would be 500 rupees. Okay, so it depends the qualification I have or the area where I work, and it changes from dentist to dentist. So usual fee will be changing, customary fee will be common for an area and for a particular qualification. But for non-participating, that pre-filing is not required. Okay, so participating dentist patients will be of only Delta dental plan. Non-participating dentist can take any dentist, any patients, even from outside the Delta dental plan. But the participating dentist get reimbursement in 90th percentile, but he gets just 50 percentile, but he gets patients from outside also. There will be fee auditors, there will be inspection, but here there is no fee auditing, there is no inspection, and there will be some amount of fund goes to the reserve fund, Delta reserve fund. Here they don't need to give any Delta reserve fund. This is what we were seeing regarding the public health program, that is Medicare and Medicaid, Blue Cross Blue Shield. Medicare is 18th Amendment Act 1965 for people aged 65 and over. It has got two parts, Part A, Part B, hospital and supplemental medical insurance. So the dental segment is limited because they need hospitalization, whereas Medicaid is the 19th amendment of Social Security Act. Inpatient care is there, outpatient care is there, lab X-ray service, and early and periodic screening program for individuals under 21 is there. Blue Cross and Blue Shield is another public health program where the payment is at 50th percentile. It is actually the association of 38 separate health insurance organizations. So Blue Cross started in 1960 and Blue Shield in 1948, and they merged in 1982. It is just like another non-profit organization like Delta Plan. So we have two non-profit organizations, one is Delta Plan and the next one is Blue Cross and Blue Shield. So that was all about finance in dental care. Just like I said, finance in dental care is very confusing. It is completely hypothetical scenario where you would not understand the hypothesis what I was talking about. So only thing is you need to understand the usual and customary fee. That was little confusing. Usual fee is a fee charged by a dentist. It can be anything because that is his choice, his autonomy. Whereas customary fee depends on the area where he works, and it depends on the qualification. It is not decided by the person. Okay, it is amount which is present in that area. In a town where BDS people can charge this much, MDS people can charge this much. That is a customary fee. And when these two becomes almost same, because I charge 500 rupees for scaling and the customary fee is present in that area for my qualification is also 500, so my fee become reasonable. Similarly, this deductible co-insurance and group insurance, deductible is front-end payment. There is no percentage sharing. Co-insurance is percentage sharing. Similarly, the UCR mechanism I told, table of allowances and fee schedule. Table of allowances, the problem is sometimes there will be additional payment has to be taken from the patient. Similarly, fee schedule, it takes the mean payment, and in this scenario 90th percentile is a concept. It is a number of percentage or number of observation lies under which 90th value or 50th value or 40th value. So that was about health insurance, the finance in dental care. So we have the last session that is coming in 2 days. Hopefully, it includes research methodology, biostatistics, ethics, it's a main chapter, then many short notes, practice management, health agencies, and many short notes. So I have not completed it. We have many short notes like palliative care, contingency management, social norms, taboo, monitoring and surveillance, public-private partnership, home, WHO, and many short notes are yet to be added. So hope you understood this part 6. Okay, so we studied today finance in dental care, dental auxiliary, and the national healthcare delivery systems. So I'll come up with the last part in my next session within 2 days. Thank you.